with a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim York.
Good evening and welcome to Dialogue with a Doctor. We're here this evening with Dr. David Ornstein. He's a urological surgeon and actually specializes in oncology of the urinary tract. And we welcome here, and he works with 21st Century Oncology,
Yes.
Correct? Okay.
Doctor, just give us a little background about yourself, how long you've been in Naples, where your offices are located, and your medical background, where you came from.
I've been here 3 years now. We have offices in downtown Naples, Physician Regional Medical Center on Pine Ridge, and Estero. And so we have the area pretty well covered. I started my career and went to medical school in St. Louis at Washington University, and then did my urology training there, and then went on to get specialized training in oncology at the National Cancer Institute in Bethesda, Maryland. And after that, I took a job on the faculty at the University of North Carolina, specializing in oncology, prostate and kidney cancer and bladder cancer being the primary areas of focus. And at that time, I also did some basic science research to look at the etiologies or the causes of prostate cancer, and to look at some methodologies to improve how we detect prostate cancer, to look for a better PSA test, if you will. And then I was there for 3 years, and I got recruited to the University of California in Irvine by Dr. Ralph Klayman, who I had trained with in St. Louis, who's known because he was the first one in the world to do a laparoscopic nephrectomy. So he's really considered the father of minimally invasive surgery in urology, for at least in regards to the oncologic aspects. And so he recruited me out to California because they were starting a robotic program, because they had advanced pretty far with the laparoscopic approach in terms of removing kidneys and some other basic surgeries. But when they tried to introduce that to prostate surgery, it was a challenge, and the results were not as good as they'd liked, partly because they're working in a two-dimensional environment. And we all, day-to-day life is a three-dimensional environment. And when you're doing surgery, traditional surgery, there's a lot of important details that you can see in 3 dimensions that are hard to appreciate in a two-dimensional or flat-screen world. So a company, Intuitive Surgical, developed this robotic surgical system that allows a surgeon to work in a 3-dimensional environment, still through small or hardly any incisions, essentially keyhole surgery, like they were doing for traditional laparoscopic procedures. And the company developed that in early 2000, and the University of California was one of the first institutions to invest in that technology. And with Dr. Klayman's leadership, he developed a program out there and recruited me to help work on that program and help develop the techniques for robotic surgery for prostate cancer. And then we expanded into the use for kidney cancer and bladder cancer as well. So that sort of took me around.
Wow.
And then for family reasons, my wife wanted to get closer to the East Coast, and her family is nearby, and so here we are in Southwest Florida, but enjoying it tremendously.
Great.
So you've been to some pretty impressive places. The National Cancer Institute, I didn't realize they trained fellows there or residents at NCI.
Yeah, they have a fairly robust urologic oncology training program. Mm-hmm. Historically, it had been part of the surgery program. And then just over the last, I think 10 to 15 years, they developed a specialized urology training program. So these are urologists who have already finished the traditional urology training, which is usually 5 to 6 years. And then this is an additional training for 2 years that combines basic research, clinical research, as well as clinical care in their clinical center. And most of the patients taken care of there are on some sort of research protocol. So all the patients that they're taking care of there, they're trying to learn something from, either develop new surgical techniques, and mostly for cancer, and try to improve cure rates, to try to reduce the side effects, that kind of thing. There are also a lot of trials developing new drug therapies, You know, in our case, actually, a big focus of one of our research programs is just to look at new ways to detect cancer from developing new blood tests, and prostate cancer was a big area of focus.
I remember when you came to town, you came to my office, and I didn't even know at the time that you could do robotic surgery on the kidney or the urinary tract. So Dr. Ornstein brought this to Towns. So you tell us a bit about what you want to talk about tonight. You're talking about prostate cancer surgery?
PSA testing or...
Well, I know, you know, it's, you know, one thing that I found, you know, Mark, we get all excited in the profession about these new technologies, and everybody wants to treat cancer. You know, we've got these high-end radiation techniques, we've got robotic surgery, you know, and that's all great. But at the end of the day, I mean, what's really important is the patient, not the technology. And you know, do we need to treat all the cancers? Do we, you know, I mean, you got to treat the patient and not the cancer, not the lab test. And what we're finding more and more is that not all cancers are created equally. Right. And there's certainly lots of cancers that we know are very, very devastating, you know, and cause very significant problems to patients, and you know, even in loss of life and much suffering. But there are certain cancers where patients live with, and they live with fine. And prostate cancer is one of the ones that has a very wide range of how it presents and how it behaves to patients. And there's lots of men, and that's where I think a lot of people have seen the public controversy over, is that we know on one hand, you know, prostate cancer is the most common cancer that men get, aside for skin cancers. And it's actually the second, or tied with colon cancer, the second or third most common cause of cancer deaths in American men, on one hand. But we also know that it's extremely common to have prostate cancer that would never cause you a problem. And we know when we look at men who pass away from other problems and they examine their prostate, a very large of those are going to have prostate cancer. And so we know that those are probably cancers that were just sort of simmering along there, not ever really causing problems. So that's, I think, where a lot of the controversies come from, is that you hear some people saying, well, we know all these men have prostate cancer, it never causes you a problem, why are we bothering treating them? And then on the other hand, we're saying, well, look, there's a lot of men out there getting prostate cancer, suffering from it, and even dying from it. And so that's where I think a lot of the controversy is. So I think it's very important, before you start getting too excited about new technologies to treat cancer, is to really understand what's going on. What does this cancer mean? What is, you know, because everybody is, you know, we've sort of been ingrained in our lives that, you know, the big C, right? Nobody wants that diagnosis. And I think what's actually happened over the last decade is we're starting to understand much better that cancer isn't necessarily a death sentence. And it's becoming much more of a chronic disease that can be managed, and much more of something that we can think about, that it's just not, you know, one shotgun therapy, that not all cancers need to be treated aggressively, and that we're understanding it involves a wider constellation of symptoms and problems. And so, you know, I think it's very important that we start, you know, we sit down with the patient to really understand, you know, about first about the patient, because the same cancer in you may be a different problem than it is for me, or, you know, or your parents.
Right.
So, you know, you got to understand what's going on with the patient and their general health and all those factors, and then the specifics of the cancer. And there's certain clues to understanding how aggressive that cancer is. Like, for example, with prostate cancer, what's very important is when the way you diagnose prostate cancer is the urologist will do a biopsy of the prostate. Sounds a little gruesome. It's usually a probe, you know, through the rectum, take some ultrasound pictures. It's one of those things that sounds worse than it is. I mean, most patients tolerate surprisingly well. You take some thin samples with the needle, and then the pathologist will look at it under the microscope. So they could say, well, the cells look normal, or they'll say it looks like cancer. But what they won't just say is cancer, they'll give some description, and there's something called a Gleason score. And that's how the cells appear organized under the microscope. And based on how that Gleason score, how that comes out, and usually it really is a score from 6 to 10, that will help give us clues as to determine how aggressive that cancer is, how much of a problem that would be. In general, the high grades, 8, 9, and 10 cancers, are the ones you have to worry about most.
Right.
The Gleason 6s are ones that may not cause you a problem that you can keep an eye on. That's all very important information. The other thing that's very important is the PSA. And everyone's heard a lot of controversy about the PSA. It's not a good test. And that's almost a different topic as to whether it's a good test to help diagnose cancer. And we could talk a little bit about that. But first, in regard to a test to help determine how severe your cancer is. So those are patients who already have cancer. The PSA value is extremely helpful to help determine how severe the cancer is. So if your PSA is very high, then you have to be very concerned that the cancer is involving a large portion of the prostate and may have even spread behind. If you have cancer but the PSA is very low, then it's less likely that the cancer is more extensive. So combining the Gleason score, how the cells appear under the microscope, and the blood test PSA helps the urologist get a sense, or radiation oncologist or medical oncologist, whoever the physician is, give a sense of how severe that cancer might be. And so in that regards, and so once you get a sense of that, and putting together the patient's general health, then you can determine, is this a cancer that's likely to cause the person a problem? If it's not, then maybe they don't need to be treated right away. And that never means, and we have lots of patients, I have lots of patients in my practice, as much as exciting as it is to do robotic surgery and as gratifying as it might be, we have a lot of patients that we diagnose with prostate cancer or come to me for a second opinion and say, you really don't need, and they come to you actually asking, they want robotic surgery. I'm like, you actually don't really need that. We just need to keep a close eye on it. But what we never do is just send somebody away, and we would never, you have a cancer, don't worry about it.
Right.
But what's important is to understand is that you can monitor things because of the blood test. I mean, that doesn't mean, you're definitely going to be okay, but it means that we can closely monitor you. Like you might monitor somebody with diabetes or high blood pressure. Doesn't mean you need to be treated right away, but if something were to change over time, that may be the indication to intervene. So there's a lot of options out there.
If I could, to clear up, at least in my mind, the latest controversy about the PSA, whether we should do it or not. In my view, it has nothing to do with whether you are following a patient with cancer and using the PSA. That is standard operating procedure.
Yes.
The question is whether you should do the PSA every year on a patient who doesn't have disease, and then what do you do with it afterwards?
Well, I picked the easier. I moved right to the easier topics. I was afraid I wouldn't get away from here without that.
That's probably a good idea because we could waste a whole hour on that subject.
So but I think it is actually important for people to understand, because I've had some people who have prostate cancer that were checking the PSAs and they're like, oh, but I read it's a worthless test. I'm like, well, no, for you it's not. So I think it's important to understand that PSA is an incredibly valuable test used in the right circumstance. Mm-hmm. And clearly patients with prostate cancer, who are on active surveillance, who have had treatment, PSA is a very important adjunct to monitoring how they're doing. So that is, and I know that's not controversial in the medical community. It's just sometimes I think in the lay, sometimes people misunderstand that. In terms of what you're talking about, there's one thing that's important to understand. There's a difference between detection and diagnosis. And what diagnosis means a test or something that tells you you've got cancer. And so it's different for different cancers, but for prostate cancer is diagnosed by a biopsy. You would never treat anyone for prostate cancer without a biopsy for most situations. The PSA test is used for detection, so what that's used to is to determine your relative risk, and based on that will help determine whether you should get a biopsy. So, if you were aggressive in trying to detect prostate cancer in everybody, you would do a biopsy in everybody. Now, of course, that wouldn't make any sense. It would be, very unnecessary costs, unnecessary risk to patients, and so we would never consider doing that. So what the PSA is really being used to say, okay, well, this is what your relative risk. If the general population, if somebody walks into your office who's perfectly healthy, has no problem, prostate problems, no other symptoms, and you say, their risk of having prostate cancer may be 5 or 6%. And so and you don't have anything else to determine, then you couldn't determine in the past, we wouldn't do anything then. And then they would wait till you had a symptom or until you can feel something on exam. At that point, then the chance you had prostate cancer was pretty high. And if you did a biopsy, most of the time you'd find cancer. But the unfortunate thing is, most of those patients, the cancer had spread too far and you couldn't cure them. There was no chance of doing surgery or radiation. So, actually, we're in the early 80s, Dr. Catalano, who I trained with at Washington University, came up with the idea that if you use the PSA blood test that had already been used to monitor prostate cancer, if we use this to draw it on patients who don't have any symptoms or risk for prostate cancer, can we help pick out those that have a higher risk?
I see.
And that's what they did.
Yeah.
And so it does. So the fact is the PSA blood test is actually the most useful blood test we have to screen for cancer. So that's the positive. The negative is that if your PSA, and people have argued what the cutoff should be. Most people use 4.0 as a cutoff for all men, and then for younger men, and we could argue what a young man in Naples is, but use 2.5 as a cutoff. And so, so if the PSA is above that threshold cutoff, you say, oh, you're at risk of having cancer, you should have a biopsy. But in reality, only about 20% of patients with a PSA over 4, between 4 and 10 actually have prostate. So that means, upwards of 80% of men who are told they have an abnormal PSA don't have, are totally normal,
Right.
totally healthy.
And they're getting biopsies.
And they're getting biopsies. So there's a lot of, there are more men out there walking around that have had an elevated or abnormal PSA and had a biopsy that didn't have prostate cancer. And so that's where a lot of the controversy comes in.
We're going to take sorry to interrupt, we're going to take a short break, just for a few minutes. And we'll be back with Dr. David Orenstein, a urological oncologist, after a short break, talk more about prostate cancer robotic surgery.
I had been a practicing orthopedic surgeon for a number of years, and I thought that I was invincible to the multitude of medical problems I saw around me every day. Was quite shocked when I received a phone call telling me that I had cancer of the prostate.
Dr. David Spellberg of Naples Urology Associates is the local specialist in treating prostate cancer with the new CyberKnife radiation treatment.
Once I got myself together was to do as much research as I could, and what I was looking for was a treatment that would give me the least risk of complications and side effects. And that's where the CyberKnife came into the picture.
Advanced CyberKnife technology, precise. It sends just the right dose of radiation to the cancerous areas, fast. Each treatment is only 1 hour, non-invasive. This outpatient procedure has almost no side effects.
The day after my treatment, I was out playing golf, and I'm looking forward now to continuing to enjoy a long and happy and comfortable life thanks to the care of my team of doctors and to the CyberKnife procedure.
Learn more about CyberKnife and Dr. Spellberg. Call today.
Welcome back to Dialogue with the Doctor. Once again, we're here with Dr. David Orenstein, a urological oncologist from 21st Century Oncology. Actually, urological surgeon is what I meant to say. And we're going to talk a little more about prostate cancer robotic surgery.
Yeah, I think we can spend all day
That's right.
talking about, whether we should use PSA for screening and who to treat and how to treat. I do think what we are moving to the direction that if you decide that you should get your PSA, and you and your doctor, and you get a biopsy, and it shows it's cancer, and then you go through all the things, and you decide that you should be treated and that you want to have surgery to be treated, the standard treatment now is robotic surgery to remove the prostate.
Right.
And the reason for, there's several reasons for that. I mean, the number one reason, really, the patients do better. There's less blood loss. I mean, in our hands, the risk of needing a blood transfusion from robotic surgery is less than 1%. You know, it's probably much less than that. The patients stay in the hospital, you know, usually less than 24 hours, while with the open surgeries, typically at least 3 days. Most of our patients wear a catheter for 4 or 5 days rather than 2 weeks. So there's significant patient advantages to doing that. There are also lots of surgeon advantages which translate to better results. Because what it does, and we talked a little bit about this, but just to refresh you, what the robot really is, it's a master-slave system. And so the robot's called Da Vinci because Da Vinci described a machine that a human has to operate. So this is not the robot in the sense of the Godzilla, that the robot can gain intelligence or ever do the surgery on their own. This is a robot that the surgeon controls. But what it does is it makes the surgeon better at what they do. And because of that, and the reason why is because by looking through essentially goggles like this is how we're operating like this in a three-dimensional environment. Everything is magnified, so the details are much more apparent to the surgeon. And the details for prostate cancer surgery are so important because right close to the prostate sits the nerves, neurovascular bundles for erections. So it's very critical that you see the difference between the neurovascular bundles and the prostate, because you don't want to damage those, because most of our patients want to preserve their erections, and you don't want to cut into the prostate and leave cancer behind. Also, the urinary sphincter is right close to the edge of the prostate, and you want to be able to see those details. And so with the magnification of the robotics in the 3 dimensions, you can really see those structures much better than you could see with traditional open surgery, and have a much better chance of getting the nerves off of the prostate without leaving any of the cancer behind, and preserving the urinary sphincter. It also allows, there's also just some advantages, and then the surgeon's able to, once the prostate comes out, the bladder has to be sewn back together to the urinary channel. And because this allows you to get right down in there, you're able to do a better closure. And so, traditionally we would put 4 or 5 sutures to hold the bladder and the urethra together. And sometimes there'd be some leakage of urine, and the patients would have to have drains out of their abdomen for several days. That's all gone away because what we do is, we can do a running suture, and then we test it because you could see so well. And so we know 100% sure that there's no leakage of urine, so we don't even need to leave a drain. And if there were ever a situation that wasn't perfect, we could just redo it or fix it right there and then. So we can pretty much guarantee that we'll have a full watertight closure.
How big is the prostate? Just
Well, it's
sorry to interrupt.
Normal. Well, it's a good
think-
question. Well,
yeah.
the prostate can grow quite a bit with
Right,
aging.
exactly.
A normal prostate in a 50-year-old man is about the size of a walnut.
Okay.
A little bit smaller than a golf ball. But most of the patients have a little bit of enlargement. So most of our patients, it's at least the size of a golf ball.
Okay.
But we got plenty of guys who go to a baseball,
Really?
grapefruit. Haven't quite seen a bowling ball, though. We've gotten close. But
So what you're describing, I mean, is it also because you're easier to work, way down in the field without your big hands being there, and you're using these smaller
absolutely.
instruments
Magnify.
and plus your eyes are right there.
Exactly.
where
So,
everything's happening.
robotics is starting to be used for a whole host of things. But it's really, its best advantage is in the pelvis. Especially a normal-sized male, the prostate's pretty deep, pretty far from where the skin is. And so when you're doing open surgery, you're using pretty long instruments, and you're looking into a deep hole. And what the robot is, it gets you right up close. So you're actually, it's not, when you're operating on the robot, it's basically like sitting at this table, working like this. The other thing that people don't realize is, a lot of surgery is uncomfortable. You're wearing a gown, you're leaning over, you got a crook in your back, and you're trying to do a very fine dissection, They're trying to make sure that the patient has as potency left and their continence, you know, and you're doing this work. You'd think like nobody composes a symphony or, you know, a physicist, you know, solves some problem while they're standing on one foot and the bad temperature. So you're going to do better work if you're sitting comfortably in a chair like this. And the robotics allows you to do that. So the surgeon sitting in a chair, the temperature is fine. You know, you've got to, you know, you can make sure you're perfectly comfortable. And they've actually set the, you know, the latest robotic has a, you know, personalized setting. So you just push a button and it gives you, you know, so everything is adjusted like you have in your car.
Car seat.
So everything is adjusted.
Memory.
Yeah, exactly. To how, and so you're perfectly comfortable. And so so you can focus 100% on doing what's best for that patient rather than some of the other, you know, human factors that come into it. So it, you know, that makes it much more reproducible. Now the other thing that was really exciting is that it's going to be a platform for going beyond traditional surgery. Traditional surgery, we just look at things like we're looking at right now.
Right.
But what they're starting to introduce is ways of looking at a deeper, like at a microscopic level or cellular level. So they're using fluorescence, different technologies that will help us look beyond just your skin, but to actually go deep into beyond what the tissue looks like, but actually at the cellular or maybe even molecular level. So I think this is just the tip of the iceberg. So I'm quite certain by the end of my career, people will look back at traditional surgery as almost barbaric, that we're just taking out a whole prostate. That, you know, someday I'm sure that we'll get to the point of actually just looking for the cancer cells.
So you mean it will be mapped
Yeah.
in some
Yeah.
way?
And this is a platform to give you better imaging. So to go beyond what you could just see with standard light, but using, you know, different visualizing technologies such as fluorescence or infrared spectroscopy. Those are just buzzwords, but there's different technologies out there to help us look into tissue, look into cells. I mean, you know, I mean, it's possible now for like for the fertility world. I mean, they could grab one egg and one sperm and inject it in, and so that, you know, you're looking at very fine details. So this is just a platform to let you do that. And the other thing, the other advantage of the robotics, so you've got the visualization is enhanced. It's bringing you close to the environment. It also allows you to do more precise motions. So it's like if when they work on the space shuttle,
Right.
you know, moving those things with their hands, they're using joysticks. And the same thing with microtechnology. So it really allows you to get down there. So, you know, it's been tremendously exciting. And I think what the good news is that although there's still controversy as to who should be treated and when to do all that, for those patients who need treatment, I really think that we're much better at providing them treatments that will have a very high chance of cure and minimize the side effects that have traditionally been associated with prostate surgery. And now we're moving this on to the treatment of using the robotic for the treatment of kidney cancer, bladder cancer, and we've done a number of those.
We'd like to thank you very much for coming. We learned a lot. We'd like to learn a lot more, but someday we'd like to have you come back.
Very
And,
good. Thank you for
We
coming.
thank Dr. Ornstein for coming, and we hope to see you back.
Yeah, appreciate it.